All right. So like I did indicated, we are starting with suicide. Oh, yes. So we're looking at suicidal thoughts, suicidal ideations, cues in terms of suicide, which are the people or which people are more risk of suicide. I met a question and the question will give you about 3, 4 people. Let's say 4 clients, and they will ask you which of them is at highest risk of suicide. And so you need to now look at how many risk factors that each of them has. Then you now come together to identify whoever is at risk of All right, thank you, Madam Anita. So if you want to make a contribution, use the raise hand button so that you'll be called to come. Thank you. Today, my co-host is doing a very great job. So I was making I was given a scenario where you'll be given about 4 clients, and out of the 4 clients, you'll be asked to choose which of them is at highest risk of committing suicide. And so you would have to now compare the risk factors that each of them contains. So suicidal clients are mostly people who are depressed. And so when we did depression or major depressive disorder, you realize that in major depressive disorder, one of the main things that when you are monitoring for such clients, you watch out for is suicidal tendency, or suicidal ideations, because of the fact that they are more depressed. They feel like they are not worth to even live. So worthlessness, they have guilt, hopelessness, and all that put together makes one to feel like the person should end his or her life. So suicide are more common with people who are depressed or in depressive clients. They feel that they are unable to go on with their life, and so at the end of the day, they feel like they should not even be alive and want to take their life. And so when you are doing depression in general, watch out for what we call suicidal tendency or suicidal thoughts. It is very common with them. And one key thing again is when you are monitoring a depressive client who is on antidepressants. One of the main things we say we watch out for is what? Watch out for tendency to commit suicide after one has started what we call antidepressants. Why? Because the moment they start the antidepressants, they will tell you that they have gained some form of energy all of a sudden. Or the moment the person starts the treatment, within some few days, the person tells you that my energy level has gone up. The moment you have a suicidal or you have a depressed client telling you that, what it means is that the person is thinking of probably committing suicide. So you have to be very watchful for such people or for such questions. The next, caring for depressed clients, always consider the possibility of suicide. So like I was saying, when it comes to suicide, it's more common in people who are depressed. And I think some of us here might have had such an experience that maybe you've had such a traumatic situation where you become so much depressed. At the end of the day, you start thinking of, should I take off my life? I have such experience before. I had a very traumatic life experience some time ago, and then I was sitting there thinking, should I end my life or what should I do in my life? So if you are caring for someone who is depressed, you need to watch out for what we call suicide. It's very common with them. Now let's now come to suicidal risks. Who and who are at more risk of committing suicide? And so this is where you get the questions about suicide. This is where you need to look at the risks for suicide. So the risks are people who have previous history of suicide attempts. And so if someone has had a previous attempt to commit suicide, the possibility that the person will commit suicide again or the person will try or attempt to commit suicide in the future is also high. So clients with a history of previous suicide attempts are one. So when you get your options, start looking at the options. What are the risk factors that each patient has? Then you put each together, then you get which of the clients will be at more risk of committing suicide. Then we take family history of suicide attempt. It's also part. we have adolescents. It's also quite very common in adolescents, especially the example I was giving where we say that I was saying that the person will start antidepressant, and then that very scenario is more common among adolescents, where the person will start treat, and sometimes the adolescent too, it has to do with some form of peer pressure, some form of challenges the person will encounter in life whilst the person reach adolescent. If the person doesn't get that needed support, okay, the person could end up thinking of committing suicide, just like the example I was giving using myself. And older adults, when it comes to the older adults, it is more common in people. You see, when you take the Maslow's hierarchy of needs, what is the last one? I mean, self-actualization and those kind of things. Now, when you get the older adults who at around 60 years of age going, and the person look at his life and realize that he has not been able to contribute much to maybe society and all that. The person is not working, maybe family support is also not good. It's very difficult for the person to even live. Okay, such people also are quite common at committing suicide. Let's say the person also have some underlying medical condition, chronic one, that is draining him or her, and the support system is also very bad. So such people are also more at risk of committing suicide. People with terminally ill clients. So just like I was saying, those with some medical chronic conditions that treating it is becoming very difficult for them. And then certain personality disorders could also put people at risk of dementia, or those with organic brain syndrome like dementia. They are all could be at risk of committing suicide. People who are depressed, we've talked about that. And then psychotic clients, so people who are hallucinating, I mean, people who are having delusions and all that, psychotic clients in general, or people who have psychotic symptoms, they are at high risk of committing what we call suicide. Substance users, okay, people who abuse substance. We talked about substance abuse, I think last week, okay, last weekend we talked about substance abuse. So people who are abusing substances are more at risk of committing suicide after taking heroin or cocaine and all those kind of medications, and then they start to misbehave. They could be at risk of committing suicide. Then peer pressure, okay, people who are those who have been consistently been bullied or rejected by peer or society would also be at risk of committing suicide. Maltreatment from, parents, let's say child maltreatment, could also be at risk. Then past history of having a psychiatric condition, or client has previously been admitted at a psychiatric unit, treated for psychiatric conditions and all that. So people with psychiatric conditions are also at risk of what we call committing suicide. So these are the various individuals who are at more risk of committing suicide. So probably what you could add up here would be people who are not working, unemployed, they are not having money, and so they are not able to get money to take care of themselves as they are supposed to. So when we look at example, you understand what I'm talking about. So when you get your question, you look at the possible how many risk factors that each person has, and out of it, you'll be able to come up with whoever you think is the one you should pay much attention to. So these are the risks for suicide, or people, individuals who are at more risk suicide. Now let's look at suicidal cues. What will tell you that a client is at risk, or the client wants to commit suicide? So these are the suicidal cues. When it comes to suicidal cues, we are looking at, first one is the person giving out their personal items, things that are more special. Okay. And so let's say you have a client, and then in the question, you've gotten a case study question, and as part of the nurse's note or the history, they tell you that the client is seen, or the client was seen selling his personal belongings, things that were so dear to the client. Let's say the client has iPhone 16. And then all of a sudden, the client starts selling, the iPhone 16, starts selling, their cars and their personal belongings. Maybe the person has ever won an award before, a special price, and then you see the person will start either selling those items or giving those items out. And so when you have such, a history of a client as part of, your case study question, you need to understand that that is a cue telling you that the person is at risk, or the person has suicidal tendency, or is thinking of committing suicide. So giving away personal, special, and prized possessions. Then counseling, social engagement, they are all, part of it. Let's say the person has some form of, some social engagement the person is wants to do, and all of a sudden the person tells you, I have stopped. The way the person engages socially, if the person, you see the person withdrawing more, it should tell you that the person probably is thinking of committing suicide. Making out or changing their will. So let's say you have a father who has a will in place due to some form of challenges. You see the person try to either make some few changes or make changes in the will that really does not really make sense. That should really tell you that maybe the person is trying to commit suicide. Taking out or changing insurance policies, positive or negative changes in behavior. So you see your relative or someone, the client's behavior has changed all of a sudden. Start acting abnormally. The moment you start seeing those kind of changes in the client, you should think that the person is want to commit suicide. So let's say someone is depressed, all of a sudden you realize that the person tells you that I have gotten some form of, energy all of a sudden. That could be a positive, change in client's behavior, but rather the rate at which the change has occurred is not expected. Even though the client has started antidepressant, we expect the change in behavior to be gradual. But if the change in behavior it's more abrupt, then that should tell you that the client probably want to commit suicide. Poor appetites, sleeping difficulties, and then feeling of hopelessness, difficulty concentrating. All this, you could trace it to people who are depressed. When we're talking about major depressive disorder, all these things we talked about them. Then loss of interest in activity. This one too is also very, very important point when you are reading your case studies. You need to, let's say the person used to like watching football like myself, and all of a sudden my favorite team is playing, and then I tell you that I stopped watching my favorite team play, even though my favorite team is doing very well, that at any point in time I would want to go and watch them. But you start seeing that things that I used to make me happy, those things I do not find them more attractive again. When you start picking those kind of cues from your clients, it should tell you that the person wants to commit suicide. So things that the individual used to enjoy a lot, if you see the person withdrawing from those activities, then that is also another cue that should tell you that the person wants to commit suicide. Then we have client's statement indicating an attempt to commit suicide. So some clients, voice it out, make a statement indicating that they probably want to commit suicide. And sadness, sudden calmness or improvement in a depressed client. So that is what I was saying in terms of changing behavior. And then clients inquires about poison, guns, and other lethal items they can use to also commit suicide. So if you are with the client who probably has a mental health issue, the client is asking about where he or she can find a gun, or where the person can get a poison to buy, then that should tell you that the person is probably thinking of committing suicide. Then sudden deterioration in school or work performance. These are all indications or cues, things that will tell you that this fellow or this individual want to commit what we call suicide. So these are the suicidal cues. Let's now look at what we do for clients who are at risk of suicide, or people who have suicidal tendencies. What are your interventions for suicidal tendency clients? So the first thing is to what? You need to assess your clients for suicidal intent or ideations. You need to initiate your suicidal precautions. So in terms of suicidal precaution, what goes into it? You need to you need to assess your patients. You need to make sure that within the client's environment, there is no form of dangerous object, or there is no form of object that the client can use to commit the suicide. And you need to initiate one-on-one supervision with your client. That goes into what we call suicidal precautions. The client statements, behaviors, and mood are documented every 15 minutes. So if you have a client who you suspect of being at risk of committing suicide, you would have to assess the client every 15 minutes to see if the client's behavior has changed or mood has changed. Remove harmful objects from the client's environment. You do not leave your clients alone. So for people who want to commit suicide, we always have to watch them. We always have to maintain a one-to-one supervision. You need to supervise your clients so that you don't leave the client alone where the client might end up committing the suicide. Provide a non-judgmental and a caring attitude as well. Encourage your client to talk about feelings and then to identify positive aspects about themselves. So that is where the self-esteem comes in. So you realize that people who are at risk of committing suicide, most of them are more depressed clients. So you need to, assess your clients, encourage the client to talk about some positive things. And then you also have to identify some positive aspect of the client's life. Then you discuss it with the clients. You need to let the clients participate in self-care. Then encourage the client to also get involved in his own personal care. You need to keep the client active by assigning achievable tasks. So this is where you need to engage the client in more achievable tasks. It could be games, it could be things the clients can do. If it's self-care that you think you can assign a certain part of it to the clients, you have to do that. You check that visitors do not leave any form of harmful object in the client's room. That is part of what we call suicidal precaution, so that the client do not get access to anything to commit the suicide. You identify the support group. You do not leave the clients. So do not allow the client to leave the unit unless accompanied by a staff member. So if you have a client who is at risk of committing suicide, what you need to do is to make sure that when the client tells you that I want to even go and use the washroom, you might have to kind of supervise the client. If the client needs to go out, you need to have someone follow the client up or accompany the client. Continue your assessment and then provide one-to-one supervision at all times for clients who are at more risk of committing suicide. So these are some of the things that we have to do for our clients who have more risks of committing suicide. And I think when it comes to the intervention, I think I have already made mention of it, that when you are taking care of a client who is depressed and the client is on antidepressants, one of the things that you need to watch out for is what? To continue to watch out for suicidal tendencies. It's a very important point that we all need to know when it comes to suicidal thoughts. So that is on suicide, suicidal thoughts, suicidal cues, and then the suicidal behaviors, and clients who are at more risk, or individuals who are at more risk of committing suicide. So if you have any input, maybe I have left something out of suicide, I did not bring it on board, and you are here, you want to add it up, or you have a question with regards to whatever I have been said, you can raise your hand so I will mute you. You come in with your question or your input, and then you take it from there. You can equally put your question or your contribution in a comment chat box. I'll call you to come in, and then I'll read it out so that you come in. Yes, let me unmute this. So there's a hand up. Let's listen to her. I've asked for a mute, so she'll be able to talk.
Hello.
Yeah,
Osamingo.
yeah.
Please, As part of the interventions for suicide precautions, I was reading from Nurse Achieve, and one of the precautions was we shouldn't open the windows because they can jump through the window. Those who want to commit suicide, they can also jump through the window. So when we are managing them, we should make sure we should make sure we don't open windows. And then so any anchor in the room and telephone lines, we should take them out. That's what
Yes.
I so wanted to add.
Yes.
Yeah.
So that is those kind of wires are part of the items the clients can use to commit the suicide. All right. All right. So that is fine. So that was a contribution from um, our colleague. So she said that she also read it from Nurse Achieve that as part of precautions for suicide, you should not leave the window open because these individuals can jump through it. And then by the time you realize they are nowhere to be found, them or they might have committed a suicide. Outside they have those kind of tall story buildings. It's not like down here where, so someone is thinking, what if the windows are made of our end here, where our windows are mostly closed. Over there because of the tall building, the windows mostly you can easily open it. And so the person will jump from the window by the time you realize the client is on the floor. I think we've all seen it in movies before, where someone will jump from the window and then fall, and the person will die. So the window is easily, movable or can be easily opened. Such people can end up committing what we call suicide. All right. So that is it for that contribution. Thank you. So let's look at restraints. I'm sure a lot of people will have a lot to add up with restraints. Okay. Now, when it comes to restraining a client, we know that restraining someone has to do with controlling the individual, either by using a physical means or by using chemical means or by seclusion. When we talk about seclusion, it's whereby the individual will be kept in a room, a separate room alone. The person will be locked where the person cannot get access to come out. So that is where, so these are the various forms of, restraints that could be applied. When it comes to NCLEX, restraining clients is a major issue. It is a major issue, okay? If you restrain someone who is not supposed to be restrained, the legal issues comes in. How long should you apply your restraints? How should your restraint be applied? How should you be doing your assessments? That is what the NCLEX is going to ask you. Can you apply a restraint without the healthcare provider's prescription? That is the question you ask yourself. Okay, so let's go into restraint. So restraining has to do with the physical parts, the seclusion, and chemical. Physical, like I said, where a physical or, environmental means of controlling an individual's behavior or actions that inhibit what we call free movement. So here we are, if in instances where you are using a physical restraint, where you have your rope there, where you have to use to tie an aggressive client, or do you even know that even the bed can be used as a form of restraint by raising all the four sides of the side rails? When you raise all the four sides of the side rails, it forms part of restraining the client, because some clients might not be able to jump or might not be able to, the whole idea is that if you raise all the four sides of the side rails, you have restrained the client. So it is not advisable, or you are not supposed to raise all the four sides of what you call the bed. If you do that and the client is not having a restraint order in place, the client can see you of what we call restraining. Okay, so let's understand that also forms part of what we call physical restraint. So using the client's environment to kind of restrict the client's movement, or using any form of physical means to restrict the individual's movement, free movement, form part of what we call physical restraint. Seclusion, like I said, keeping the individual, where a type of restraint where the client is confined in a room specially designed for protection and then close supervision from which the clients cannot freely exit. So in most of the psychiatric units, they have what we call a seclusion room, where that place is specifically designed to keep individuals probably who are more aggressive. You keep them there to prevent their free movement. Before you can put such a client or you can put someone in seclusion, you need to have a restraining order in place, or you need to have, there should be a reason for you to seclude a client. Without any reason, if you seclude a client, it forms part of restraining, the client can see you. Then chemical restraints, where we use what we call medication. So all of us here, we've been doing it. You have, a client who is a little bit aggressive. You find it difficult controlling the client. You end up giving the client diazepam so that the client will be more relaxed. Now, if the client doesn't have such an order in place and you give it, and the client becomes more sober, more relaxed, so that you could go about your daily activities, what you need to understand is that the client can see you, not that you might be seen. The client can see you at the end of the day of being restrained. So before you use any form of chemical restraint, or before you give clients a certain form of medication in order to control the client's behavior, or to inhibit movement and all those things, you should have such an order in place, or there should be a reason for you to do that, so that if that order wasn't even in place, after which you get a healthcare provider informed, so that the healthcare provider can come in and then make the order or write the order down. So medications given for the specific purposes of inhibiting a specific behavior or movement, and that have an impact on the client's ability to relate to the environment. So typical one that we all use are the benzodiazepines, diazepam being an example, a typical example of it, where you give it to the client and the client becomes more relaxed and sober. Now let's look at instances where you can use restraint. So at what point in time are we allowed to use restraint on a client? The first one is restraint and seclusion should never be used as a form of punishment or for the convenience of the healthcare staff. So let's say you have a client who at night became a little bit confused, a little bit aggressive, and then you ended up, instead of you maybe continue your monitoring, looking at if there's going to be any form of change in behavior, you ended up giving the clients what we call diazepam so that the clients can relax, so that you can have your free of mind to relax. When you do that, that is not restraining. When you do that, the client can see you. Or let's say you are using restraining as a form of punishment. Restraint should not be used as a form of punishment. So this is where, let's say you have a client who is a little bit aggressive, and then you threaten the client that if the client doesn't, stop what behavior the client is exhibiting, you give the person this medication. When you do that, you can be sued for either what we call assault or battery. Okay, so you should be mindful that you should never use restraining as a form of what we call punishment or for convenience sake. Restraint and seclusion are used when behavior is physically harmful to the client or others, and when alternate or less restrictive measures are insufficient in protecting the client or others from harm. So this one is well explainable. You have a client who has become more aggressive, dangerous to self and other people. These are the instances where you need to apply your restraints. Okay. Restraints and the seclusions are also used when the healthcare team anticipate that a controlled environment will be more helpful, and then request what we call a restraint or seclusion. So that is also from what we call the healthcare team. Let's say the healthcare provider comes out, on assessment and realize that the client needs what we call certain form of restraining, maybe to control the environment or to control the clients. Maybe client is more aggressive. Maybe client sometimes becomes confused, and when they become more confused, they become more aggressive. And so in that instance, you might need to have what we call a restraining order in place from the healthcare provider for that. The nurse must also document the behavior leading to what we call the use of restraint. This is very, very important. When you use a restraint on a client, you need to indicate the reason why you apply your restraints. And then in most settings, we all know that before you apply your restraints, you need the order from the healthcare provider, or you need an order in place from your healthcare provider that apply what we call restraints before you can apply restraint on the client. And the last part is that there's an exception to that point, the point I just made, that in most instances you need an order from the healthcare provider, but when it is an emergency, okay, when it is an emergency, the nurse can restrain a client. But the moment you restrain a client, what you need to have in place is that the moment you should restrain a client, the next thing you have to do is to inform the healthcare provider, either to get a written or a verbal prescription as soon as possible after the restraint has been applied by yourself. Let's say you are caring for the client, you realize that all of a sudden the client was in a group therapy, the client has become more aggressive, you have removed other people from the client's environment, but you realize that you need to control the client's behavior. So you have to seclude the client. In that instant, when you seclude the client, they move after, just after you have secluded the client or you have restrained the client, you would have to inform the healthcare provider about that, so that the healthcare provider will either give a verbal, what we call prescription, or a written prescription will be made available so to protect yourself. Okay, all right. So someone says that she saw, he or she saw a question, and question it was time bound, right? That within 1 hour you have to get what we call the order from the healthcare provider. So thank you for your addition. Okay, all right. So that is within 1 hour after applying what we call your restraints, you will need to get what we call the order, either by verbal means or a written order from the healthcare provider. So let's look at other areas when it comes to applying restraints. Stated guidelines within, yes, so within 1 hour, I think it's even here. So within 1 hour of initiating of your restraints, the psychiatrist will need to come and do face-to-face assessment. So where, let's say you had a patient who was a little bit aggressive and you applied your restraints without an order, you have to make sure that within an hour you get your healthcare provider coming in to give the order, so as whether you continue with your restraints or you have to take the client off from what we call restraint. The healthcare provider will need to come in, or the psychiatrist will need to come in to do assessment evaluation of the client, and then must continuously reevaluate the need for continued restraints or separation. Whilst in restraint or separation, the client must be protected from all sort of harm. And so if you have your client, in terms, if they have applied restraints, that's where you need to continue to assess your client. You need to assess your client, especially if you apply some ropes. You need to remove the rope, and to do assessment, you need to assess the need for physical needs, that is food, elimination in terms of, bladder needs, or controlling the bladder and bowel needs. You need to assess for all those things. The client in restraints or separation needs constant one-to-one supervision. Physical safety and comfort needs must be assessed every 15 to 30 minutes. So that is where you have to assess your clients every 15 to 30 minutes for physical needs and safety. So let's say you have your client, you have applied your restraints. You need to assess the client every 15 to 30 minutes. So this is you, the nurse, for any form of, let's say, clients will need to drink water, clients will need food, or clients will need to use the bathroom, or what you call range of motion exercise and ambulation. You need to assess this need every 15 to 30 minutes. Then the nurse must always follow agency protocols and procedures regarding the use of restraint, and must also be familiar with the use of their use for the older clients and juveniles. Restraint require a written prescription by the healthcare provider, which must be reviewed and then renewed per agency policy. The prescription must specify the type of restraint you are to use, the duration of the restraining, and the criteria for release based on agency policy and procedure. And so that is on restraining in terms of what you have to use. After obtaining verbal order, do you need to get a written order when the healthcare provider comes around? Verbally by phone and written within an hour. So, Madam Vivian, the thing is that you need either of them. Okay, you need either of them. If you can get the healthcare provider to come in person to give the written order, the healthcare, let's say the healthcare provider cannot come within that very 1 hour to come and give the written order. That one, it can be done on phone. And then later, the healthcare provider will probably come back, maybe, and then also continue the assessment. So if the healthcare provider comes and then continue the assessment, and then in that instant, I believe, because the healthcare provider is present, the person is likely going to give a written order, not a verbal order again. The verbal order is when the person is not available, and then you have to get the person maybe on phone for what we call the order to be made. And so this is on restraining a client or the various situations where you need to apply your restraints on the clients. I think I've left something out of restraining. What have I left out? Is there something I have left out from restraining? If you think I've left something out of restraining, you want to add up, we can bring it up so that we talk about it. And then when it comes to tying your rope, I've forgotten the actual term they use. Okay, when you are tying it, you need to tie it. Oh, they have a term for it. How you tie your rope so that you can easily, untie the rope. Okay, you are not supposed to tie the rope so it should be so much tight on the client that it can cause some form of what we call injuries. Okay, and the rope should also be much more easy to be released. Mr. Kabiru's hands up, so let me call Mr. Kabiru. Probably Mr. Kabiru wants to add up. Yes. Yeah, Mr. Kabiru, you can go ahead.
Yes, I'm trying to find out something.
Okay.
When you have the various types of restraints available, which one is recommended first before the other? If there's the need to restrain the client, and then maybe you have like a chemical restraint, physical restraint, or seclusion. So which one do you go in for first? Maybe when that one finished, you now move into the other.
So I don't have a specific answer to your question, like when there is when you have 3 orders in place. But what I would say is that it all depends on the client situation. Let's say you have a very aggressive client that you cannot even hold to tie the client down, or you cannot even go near the client to give an injection to the client. Then the most appropriate probably intervention you would have to put in place is to do seclusion, to calm so that later if the client calms down. So it all depends on the situation at hand. Okay, as whether you can physically hold your client to apply the restraints. Like I said, I don't really have this, but all that I would say is that you would have to look at the client situation. Then the situation of the client will now help you to determine that which of them should I use. If the client is more aggressive, can you go near the client and try to hold the client down to apply your restraint? That is one question you should ask yourself. But let me see, I'm sure Mr. Paul also wants to come in. Probably maybe Mr. Paul has an idea.
Boss,
Mr. Paul.
mine is a different question.
Mr. Paul, you said? Hello, Mr. Paul, your line was breaking. Can you come again?
It's a different question on its own. Mine is a different question that I want to ask.
Okay. No problem. Go ahead. But your line is breaking, Mr. Paul. If you can reposition yourself again for us. Mr. Paul, your line is breaking. All right, whilst we wait for Mr. Paul to come, let me take Madam Tina.
Okay. Good evening.
Yeah, good evening,
Please,
Madam.
the phone call that we need to make to the healthcare provider for the order for restraint.
You said you need
Can
to
you
come
hear
again.
me?
Come again.
When we need to restrain the patient and the healthcare provider is not there, we need to get an order after we have done the restraint. If we
Yes.
can't get hold of the person physically, then we make a phone call. The phone call, is it a recorded phone call such that if there is need to back it in any other situation, you can play it out so that people will know that you actually had the order from the doctor verbal. Because if maybe you wrote it down, writing it down will not actually defend or give an evidence that you actually communicated with healthcare provider. So I want to find out whether the phone calls are recorded.
So in your if I understand your question well, you mean after you have, let's say you have called your healthcare provider and you didn't get your healthcare provider. Is that what you are trying to do? Or
No.
let's say you had a healthcare provider.
You have already restrained the patient, but you need the order from the healthcare provider to back what you have already done.
Yes.
Yes. So as you are calling the healthcare provider and you get the healthcare provider on the phone, is the phone conversation recorded
And that in the
in
US,
real time?
yes, the phone calls are recorded.
They are recorded.
Yes, the phone calls are recorded in
So
US.
that it can be played out.
Anytime, yes. So
okay.
In the States, I mean, the facilities, they have their phones that are interconnected and all that. If you use the phone, when they come back, they can trace every call that you made and whatever the content of the call was. So the calls are recorded. I hope you get me, Madam Tina. The calls are recorded. For that one, the calls are recorded. Yes, Mr. Paul, your line was breaking. I could not really get you well. I don't know if you can show up so I unmute you again. You come in again. So, Mr. Yusuf, with regard, yes, let me hear from Mr. Paul again. And I'm sure maybe by now I'll be able to hear him.
Okay, boss.
Yeah, Mr. Paul.
My question is about suicide. If suicidal thoughts or ideation, I think the best plan is to do one-on-one monitoring. Apart from this, in terms of can the patient be cohorting, or is advisable for the patient to be in a private room alone?
For suicidal thoughts.
Yes, please.
Right. Oh yes, the clients can be cohorted. But the only thing is that you need to do your one-to-one supervision. The reason being that when, let's say, the clients are, let's say, cohorted, okay, other people could also help the clients. And so when you are cohorting, we have the criteria for cohorting. You need to make sure that the one you are cohorting with, that the client who is at risk, okay, of suicide, you need to make sure that the client can be cohorted with that very client. But for that doesn't mean that if you cohort someone with, let's say, you cohort 2 clients, you need to make sure that for your one-to-one supervision there, it has to always, don't leave your client alone. Even if you are cohorting, you don't leave the client alone. That is the take home I just want to add up. That even if you are to cohort, you can cohort clients in that instant, but you need to make sure if you are cohorting, let's say you have maybe 2 clients or 3 clients who maybe they all have suicidal thoughts and all that, and you want to cohort them, you can do that, but make sure that you are maintaining your one-to-one supervision. Nara Beck, you want to come in, so let me unmute you. come up again so I could see you, Madam. Okay, I've unmuted. You can go on.
Thank you so much. I wanted to add up to what you said concerning what my sister wanted to know about the recorded.
All right.
Yes. Unlike in Ghana where doctors always have to be present to put in orders and things, what I know about outside is that the system is such that the doctors are not always present, but they are able to put in orders as when we call them. So after the phone calls, orders can still be put through based on how the system is structured. I know they have the email and other systems they use. Orders are able to put through, and then it will be on the system as something that can save you later.
Later.
Yeah.
Okay.
Thank you.
So those are who are already there. They have the first-hand experience to this. Okay, how the system works perfectly, not like our own here. Ms. Ayusi, your hand was also up again, so I don't know whether it was a new one or you wanted to add on. All right, so you cannot mute, Ms. Ayusi.
Hello. Yes, I have. I just saw something like relating to the question I asked. The question I asked about which restrictive residence should be used first.
Okay.
Yeah.
If you have something on it, you can let us. Yeah. Go ahead.
Yeah. They are saying that the least form of restraint.
Sure.
Should
She'd
be
always
used.
Yes, for that one there,
Yeah.
it's true. Yes. Yes.
Once taken into consideration the patient safety.
Yes.
And so that's what they are saying.
Yes.
So
yes.
so and they are saying that if maybe that one too is failing, then you switch to another one, and then you do it gradually.
Yes. So if let me throw this. So between seclusion, and then chemical restraint, and then applying ropes and other things, which of them do you think is the least restraint?
Ropes will be better.
Which one?
Ropes.
Rope will be better. Is that the least form of restraint?
Restraining the hands, and then maybe with time you can restrain one hand and then one leg, and then maybe and then maybe followed by the chemical.
All right. Thank you, Mr. Isaac. So yes, so like he said, when it comes to restraint, the protocol has always been that go with the least form of restraint. Okay, depending on the client's situation. Then, if the client's situation worsens or becomes more aggressive, you can increase. The restraint. So let's use. Using rope. Okay, when you are restraining, you would have to probably start with, let's say, one hand. And then later, if the client becomes more aggressive, you increase the number of extremities that you are restraining. That is where the least restrainings are applied. But the client situation will definitely tell you which form of restraint to use for your clients. There is another hand up, Madam Patience. After that, we will continue with this. So, Madam Patient, I think I've muted you. Yes, can you come up again? If you can raise up your. Oh, all right. She's off at the moment. So let's look at family violence, the cycle of family violence and all that. Okay, I know that you get a lot of people go and come and tell. Probably I get a question on family violence. There are questions on it. UWorld has a very nice question on family violence, a very nice one. I think it's even a case study for those of us using UWorld. You might have come across it. So when it comes to family violence, it's the same as what is the other term they use? Is it partner or intimacy violence and all that? It's the same thing. So family violence has to do with violence that occurs within the family. Let's say, we know what, we all know, let's say you are married and then the two of you, maybe you keep on getting issues, fighting each other and all that. And so we have a certain cycle that, you realize that the people, they will fight and then all of a sudden they will start vibing again. And then within some few days, they will start misbehaving again and the cycle will continue just like that. So violence begins with threats. So when you take the family violence, or when you take the violence cycle, it mostly will start with the fact that maybe someone, the abuser, will start threatening what we call the victim. And the threats could be in a form of either verbal or physical form. So the first part of it is that the abuser will first start, will not just go straight and start beating the partner or start beating what we call the victim. It's always going to start from somewhere in a form of what we call threats, certain form of threat, either by physical or verbal threat. And that is what we call the tension building phase. And so the tension building phase of what we call family violence, it's where you have what we call the verbal or the physical minor assault. And so you have the person either by insults or maybe physically just kind of touching what we call the victim. That is the first phase of what we call violence or family violence. It's first start with tension building phase. And so when you get your question, this is how the questions they mostly ask. They will ask you, at which of the cycle or which of the phase do you expect verbal or physical minor assault to be present? And you need to understand that that occurs at what we call the tension building phase. So it is at the tension building phase where we expect that kind of verbal and then physical kind of a minor assault from what we call the abuser. And the victim at that point tried to comply with what we call the request of what we call the abuser. So at the tension building phase, you have the victim, whatever the abuser will say the victim should do, you see the abuser trying to do. In the next step of what we call the cycle, you have the abuser losing control and the victim becoming the abuser losing control and become destructive and then harmful. So we call it the acute battling phase. And so that at the acute battling phase, that is where you have the punches coming in. And so the situation becomes worsens, and then they start throwing what we call the blows. Physically, they start to engage each other. The victims attempt to protect themselves. And so in a way for the victim to try to protect themselves from maybe the abuser, you see the victim also maybe in an attempt to protect him or herself, try to maybe also engage what we call the victim in what we call the fight. And so acute battering phase is where you have the situation becoming more intense. They try to, the abuser has lost control, fighting or beating what we call the victim. We'll talk about the characteristics of each of them. What are some of the characteristics of abusers and characteristics of what we call victims? So we get to understand that part as well too. Then the last phase is what we call the animal phase. Okay, so it has three phases. It has the tension building phase. It has the acute battering phase, and then we have the animal phase. So animal is where the abuser will now come back to what we call the victim, try to give promises that those actions will not be repeated again. And as a result, the victim will also try to accept what we call the abuser back, and they start to vibe again. And from there, maybe something will trigger the violence again, and the cycle will continue. The person will end up back again in what we call tension building phase. They go through the violence just like that in a cycle form. So at the animal phase, you have after the battering phase, the abuser becomes loving and attempt to make peace, calmness, and diffusion of tension. Undoing behavior is characteristics in which the abuser gives gifts and positive attention to what we call the victim to undo the negative behavior. So that is what we call the honeymoon phase. So we have that. The first phase is tension building. Second phase is acute battering. The third stage is what you call the honeymoon phase. There was a hand up. I think our colleague is back. Madam, patience.
Hello, sir.
Yeah. Hello, you can go ahead. I think I've unmuted you.
Hello, sir.
Yeah, your voice is very down. If you can raise up your voice a little bit.
Please, can you hear me?
Yes, I can hear you, but still increase it a little.
Okay. Sir, please, I went off. Can you please explain the three phases again?
Can I do what? Hello, Madam P. You said, can I please explain what? Oh. You can equally put, those who heard her can help me. Okay,
Yes.
I've unmuted you again. Can you repeat what you said?
Because I went off. Can you please go over the phases again?
You mean the phases?
Yes.
This very slide, I am on it. That's what you are asking of.
Yes.
Okay. So she says, the whole show. Let me try to, I'm coming in. Let me increase my volume from my end here. I think, okay, it's even 100%. So means her voice is what was really down. So she wants the whole show, but she wasn't with us. She said she went off. Enough for me. All right, so the whole show. Don't worry. The first phase I said is tension building phase. Okay. The first phase of family violence or intimacy violence or whatever, I mean, partner violence and all that. The first phase is the tension building phase. And so I said that at the tension building phase, you know, the situation always has an abuser and it will have a victim. The abuser at the tension building phase, mostly some of the things that characterize the abuser at the first phase, that the tension building phase, would be the physical threats or, I mean, verbal threats. So the violence will begin with threats or verbal or physical minor assault. So either the person is insulting the victim, that is the abuser. The abuser will be insulting the victim, will try to abuse her. And when it comes to physical abuse, it just may be some kind of small touches, not like throwing the hands, like how maybe they are fighting. So it will be like small touches at the tension building phase. That is the beginning of what we call the violence. It's more like exchanging of words, that kind of thing. Then what the behavior of what we call the victim at the tension building phase will be that they will try to comply with whatever the victim will say or the victim want them to do. And so they try to comply with the request of what we call the abuser in terms of the victim. So that is the first phase. The second phase has to do with the acute battering phase. And I said that it is at the acute battering phase that things get out of control. That is where they start to fight. Or you see the abuser start beating what we call the victim, and then things get out of control. Controlling the situation becomes very much difficult, become very difficult. The victim will try to attempt to control the situation. And then in controlling the situation, that is where the situation will escalate more, because the victim will probably maybe want to also maybe throw the shots too, and then it might escalate the situation. And so that is acute battering phase. The last phase is what we call honeymoon phase. At the honeymoon phase, the victim will, or the abuser will start, I mean, buying things for what we call the victim, will start giving promises that, oh, the situation will not, or the what happened will not happen again. Forgive me, it will not happen again. Let's stay again. And you have the abuser, I mean, making those kind of promises. making those kind of promises just to win what we call the victim back again. And because the victim probably also loves what we call his or her partner, you also say that, okay, I mean, no problem, I'm forgiving you, let's stay again. But family violence is much more chronic. The situation will happen again. Maybe the victim will go and will do something and it will trigger the violence again, and they ends up in tension building phase, ends up in acute battering, and then they ends up in what we call honeymoon phase again. So these are the three phases of the three cycles: tension building, acute battering, and we have the last phase being honeymoon phase, where they try to settle the scores and everybody becomes fine. Madam P, are you okay? This is what I said. All right. The abuser will justify their violence, that it is more normal, and the victim, it's mostly responsible for the situation. So you will have the abuser always trying to justify their actions, that their actions were warranted by probably the behavior of the victim. And so the abuser will always try to justify the violence, that it is normal and the victim is responsible for the abuse. Outsiders are usually unaware of what is happening in the family. Family members are isolated socially and lack autonomy and then trust among one another. Caring and intimacy in a family are absent. So if you have a family where they are continuously engaging in this form of violence, I mean, issues of trust, issues of intimacy, caring all will be affected. Family members are also, family members expect each member of the family to meet their needs, but none is able to do so. So those are some of the things that happens during, violence. We all know, or if maybe you have found yourself in a family where violence is very more predominant, these things are very common, you can relate to it. The abuser will threaten to abandon the family. And that is the reason why the victims cannot leave what we call the abusers. And so you realize that sometimes the victims are more compromised. It could be. And so if you read further, one of the Cubans, they will say that family violence mostly increases when you have, let's say, the wife becoming much more pregnant. During pregnancy, violence increases. The reason why violence will increase because the burden will come more. Let's say the husband is not well-doing socially, or is not having money and all that. And so the wife is pregnant, burden has come, then they start to engage in one or two altercations issues. Now it becomes much more difficult for the victim to leave what we call the abuser, especially if she's pregnant and then they have kids, because she feels like if she leaves the abuser, who is going to take care of the family, or who is going to take care of the children. And so that burden makes what we call the victim try to stay all the time. So the abuser threatened to abandon the family, and then because of that, it makes what we call the victim to always try to comply with whatever the abuser will say. When it comes to the characteristics of each of them, abuser and the victim, the abusers mostly they have impaired self-esteem, they have strong dependency needs, and then they are much more narcissistic, they are suspicious. And so you realize that those people who, let's say you are married to someone, a person is more abusive, you realize that those people are more suspicious. All the time he suspects that he or she suspects that the partner is probably cheating, or the partner is probably doing something bad against him or her. And so they are much more narcissistic, they are more suspicious, they have history of abuse during childhood. Probably whilst they were growing up, they were abused by their parents, or maybe they were born into a family where maybe abuse were much more common. And so a history of abuse during childhood is also, one characteristic of abusers. They perceive the victim as their property and then believes that they are entitled to abuse them. So that is why I was saying that due to certain situations, the abuser finds the victim finds it much more difficult to leave the abuser, especially when they are compromised in terms of, let's say, they have kids, the person is pregnant and all those things. They see the abuser see the victim as his or her own, and so I mean the person cannot leave. If you leave, who is going to take care of the kids? And so we also try to comply with whatever the person will tell you to do. So these are some of the characteristics of abusers. Victims, in terms of their abusers, they also have that kind of dependency personality disorder. When we learned about personality disorders, we talked about dependent personality disorder, and we learned that these people are those that are they are unable to make decisions by themselves. Making choices are difficult. They are unable to make decisions. They always have to depend on their partner or someone in order to make what we call decisions. So they have that kind of dependent personality disorder, feel trapped, dependent, helpless, and powerless. So that is where I was bringing in the fact that if the person is pregnant, they have family or they have kids, and so the victim thinks about who is going to take care of me and my kids, and so they become more powerless and start to stay with what we call the abuser. They may become depressed as they are trapped in the abuser's power and control cycle. As victims' self-esteem diminishes with chronic abuse, they may blame themselves for violence and then be unable to see a way out of the situation. And so, like we learned previously, that the abusers will always blame the victims as being the problem. And so when the abuse becomes more chronic, the victim will end up accepting the fact that they are always the cause of what we call the violence. And so it becomes very difficult for them to leave the situation. And so this is what we call the cycle I was talking about. So I've gone through this already. So this is the cycle. So the cycle, I said, starts from the tension building phase. And so the tension building phase, you have all right, there's a hand up. Let me listen to the fellow before I continue.
Hello.
Yeah, madam, kindly go ahead.
Okay, please, concerning the dependency, I'm okay with the victim being dependent on the abuser. That may be the reason why she's not able to leave. But for the abuser dependency, yeah, I don't get that side. If you can, please throw more light on that for me.
So you mean that this point, I think here.
Yes, the point 2 for the abuser.
Strong dependency needs. Do you understand that point? Strong dependency needs. So you realize that we said that the victims have what we call dependent personality disorders. Strong dependency needs means that they always, like, if they are with you, whatever you do, you would have to depend on them, or you would have to take their view, even if you can. The victim can come up with their own view or whatever they want to do. The abuser will always want you, the victim, to depend on them all the time for what we call their their decision. Okay, that is what that point means. So whatever he says is or whatever she says is what you have to pick. If you need to make a decision, it is his choice or her choice that you would have to pick.
Okay.
Madam, did you get the point I'm
Thank
making?
You. Yes, I understand now. Thank you.
So let's do this phase, okay? I think I've talked about it. So it is the cycle. This is a picture. Any book that would treat violence, you see this picture in there. And so you have the cycle there. We have the tension building phase. And so Edigi has a minor explosion. So we said that attention building, that is where the verbal abuse comes in. They try to minor what we call physical assault also comes in here. So may become verbally abusive, minor hitting, slapping, and then other incidents begin. So that is our abuser. The victim feels tensed and afraid. It'd be like walking on egg, feels helpless, and then becomes compliant, accept blames. So we talked about it from what we call our previous slide. And then we said that from tension building phase, we go to the serious battering. And serious battering, we said that is where the issue escalates, or the abuse escalates. They start to throw, they start to fight and all that. So the tension becomes unbearable. The victim may provoke an incident of the victim may provoke an incident to get it over with. And then the victim may also try to cover up the injuries or may look for help depending on the situation. So that is the second phase, that is acute battering. I've talked about that already. And then the last phase being the honeymoon phase, where gifts, they try to console each other, or they try to love. The love increases again. And so the abuser, in terms of their behavior, loving behavior, such as bringing gifts and flowers and then doing social, special things for the victim. And then you have the victim also start to trusting increase, or they start to trust again, hoping that things will get better. And then want to believe partners' promises will be in place. And so this is what we call the cycle. And that's the cycle. Okay, I've already explained it in our previous slides. Now let's look at what we do for, family violence in terms of intervention. One thing that I just want us to take home is that when it comes to family violence, never try to suggest that the abuser should leave the victim. Let the abuser understand that, let the two of them or let the victim understand the consequences of what he or she finds herself in. And let the person decide whether they will leave or not. But do not decide that the victim, don't make statement like leave your partner or leave the abuser. No. Allow the victim to decide by themselves that they want to leave what we call the abuser. That is one take home I want to make, that let them make decisions themselves. You need to report suspected abuse or actual case of child abuse or abuse of an older adult to the appropriate authorities. It's always important that we understand that we need to report when it is part of the reportable institution. So you need to report abuse. And so the appropriate authorities need to know about what you call the abuse situation. You would have to refer to the appropriate sexual assault department, mostly like our ends here in Ghana, we say, DOFSU and those kind of things. So social welfare. So the social welfare department would also need to be referred to as well. You need to assess the clients for injuries. And when it comes to abuse, when you're assessing the victim, you need to make sure that the abuser is not there. It's also one question I've met. How are you going to do your assessment as to whether you let the abuser be in the presence of the victim when you are doing your assessment? Because when the victim is there, when the abuser is there, the victim will not open up. So during your assessment, you need to ensure privacy. You need to make sure that the abuser is not in the midst whilst you are doing your assessment. You need to assess for any form of physical injuries. Ensure that privacy and confidentiality during assessment. You need to provide a non-judgmental and empathetic approach to foster trust. You need to reassure your client that they have done nothing wrong. And another thing I want to state is that when you are doing your assessment, let the victim understand, or let your client understand that you are required to report any form of abuse. Okay, it is part of the things we need to know, that as part of our assessment, or as part of our duties as nurses, we are required to report any form of abuse. So the clients will understand, or the victim will understand. So later, if he or she gets to know that you reported the situation, the person will understand why you needed to report. Then you need to assist the victim to also develop, self-protective and then other problem-solving, abilities. Even if the victim is not ready to leave the situation, encourage the victim to develop a specific plan that is a fast escape if the violence returns, and provide information on where to obtain help, hotlines, safe houses and shelter, and then an abused person is usually reluctant to call the police. And so that was the point I was making, that we do not make decisions. We do not make decisions for the client as to whether the client should leave. Let the clients know the situation, that they are in danger. Let the clients know and allow them to make decision whether they will leave or not. If the client is not ready to leave the victim or leave the situation, you have to find a way to help the client to develop a safety plan, how the client can escape if the violence reoccurs again or the violence returns again. You have to provide them with all, appropriate help in terms of hotlines, safe houses, and then shelters they can run to when the need arises. You need to assess the victim for suicidal ideations. You need to also assess for potential homicides, and then the use of drugs and then alcohol. Then you need to determine the family coping patterns and support that is available for what we call the family. Provide support and then assistance. You provide support and assistance in coping with what we call contacting the legal system. Assist in resolving family dysfunction with prescribed therapies. You encourage the individual therapy for the victim that promotes coping with the trauma and then prevents further psychological conflict. So you would have to engage the victim in some form of therapy, that is individual therapy, where they can manage their situation. Psychotherapy is also another form the clients can go for. Counseling, group therapy, all important to help the client to cope with their situation. You need to assist the family to also identify, assist the family to identify and access to community and personal resources. Very, very important. The shelters, and then those resources that are available in the community where the client can make use of them. That you maintain accurate and thorough medical health record as well. So that is on what we call family violence, and then the interventions for family violence. I saw someone, but I wasn't really getting what the person, Annie's iPhone. I don't know whether you want to come out to tell us what you correct, seeing the question a few times. Okay. And not to tell them that everything will be okay. All right. So you are just adding up to what I was saying, that you do not, have to make decisions for the clients. You need to let the clients make their own decisions as to whether they want to leave or not, and not to tell the client that everything will be okay. I think, yeah, so that is kind of promising the person. You need not to promise the person anything. Just let the clients know what is there. All right, so I think I get your point now. Thank you. Hey, can I finish what I have to do today? I want to finish this soon, so we'll finish it. I will have to borrow your small time to finish this section. Now, any further inputs, questions on what we call abuse or family violence? Sorry, before we do child abuse, and then we'll talk about adult abuse and neglect, and then I still have 3 areas I want to talk about. Wow. All right. Any further inputs? None. So I can go ahead. Now, when it comes to child abuse, we need to also know about child abuse, especially assessment findings that will help you to know that a child is being abused. Okay. They are very, very important. They are also one of the common areas you'll be meeting whilst we are solving your questions. And so we need to understand about child abuse. And so the abuse, what we need to understand is that when it comes to child abuse, the abuse is mostly non-accidental. And so it is not like the child was playing football and then had injury or sustained what we call a fracture. For a child abuse person, they will bring the person, and you see that the person has had multiple fractures, and then there is no reasonable explanation to why the child has had those kind of fractures. The child comes and then on assessment, you realize that there are certain marks on the child's body, and then the family is not able to really tell you what is causing those kind of things. And so the abuse is mostly not accidental. So it's not, the abuse is the non-accidental physical injury or the non-accidental act of omission of care by a parent or person responsible for a child. The abuse comprises about neglect. It could be physical, it could be sexual, and emotional maltreatment. And so when you look at abuse in terms of child, even in adults, it's the same thing. It comes in different forms. It can be in a form of neglect, where they are not, maybe you have a 6-year-old child who you think at that age the person should be in school, but the person is roaming around anyhow. Nobody's taking care of the child. The child is always unkept. It all forms part of what we call neglect and forms part of abuse. It could also be physical, in terms of beating, injuries, and all that. Sexually, being abusive, and then emotional maltreatment can also happen. Neglect can be in the form of physical or emotional neglect, and then involves, depriving the person of their basic needs, supervision, medical cares, and then failure to meet the child needs for attention and then affection. So that's why I was saying that you have a 6-year-old child who is supposed to be in school, but ends up roaming about anyhow, not in school and all that. So that forms a part of what we call neglect. Sexual abuse is also part of what we call the abuse, and we have different forms of sexual abuse. It could be like pedophilia. It could be engaging the child in prostitution. Watching pornography movie with the child, and then exhibitionism are also part of it. Molestation and then incest are all part of what we call sexual abuse when it's being engaged, what we call the child. Findings associated with sexual abuse may not be necessarily apparent in a child. So sometimes it becomes very difficult to assess for sexual abuse. Let's say if they are watching pornography and it's not like actual sex engaging with a child, where maybe you could see some form of injuries at the perineal area and all that. It could be sometimes very difficult for you to assess what we call sexual abuse in what we call a child. Then we also have shaking baby syndrome, which is also quite common in abusive children, or can happen when it comes to children who have been abused. But baby shaking syndrome can also occur, especially if you're a mother and then you don't take good care of your child in terms of how you handle the child. And so this is a form of a brain injury where there is no physical trauma or physical injury to the head. And this mostly happens when you, vigorously shakes the baby. Let's say, olden days, our mothers will give you enema. When they give you the enema, the way they will raise you up and down and shake you so that the way they will raise you up and shake you, that kind of shaking can lead to what we call baby shaking syndrome. And so it is a violent shaking of an infant and resulting intracranial trauma. This could lead to cerebral edema and death. So it mostly results in subdural hemorrhage. And so we need to make sure that we are avoiding what we call baby shaking syndrome, which can occur. And you need to make sure that you are not handling the child anyhow, okay, in order to prevent baby shaking syndrome. So that is on abuse, child abuse. In terms of the assessment findings for a child, this is very, very important. These points are very important points. We need to know what are some of, especially the physical abuse point or the physical abuse assessment findings. What are some of the things that physically will let you know that the child is being abused, or this child you are reading on, the question you are reading is about child abuse. And so you need to understand that when it comes to neglect, we understand that neglect is where the one responsible to take care of the child in terms of meeting the child's needs, the person is not doing those things, either in terms of nutrition, in terms of taking the person to school, in terms of assisting the person to meet their needs, that things are not being met. So that is where the neglect comes in. So if a child is neglected, some of the things that you're going to see will be inadequate weight gain. And so you see the child will be at, let's say, 10 years of age, and the child is weighing, let's say, 7 kg. Or the child is weighing, at 10 years, someone should be weighing over 20 kg and those kind of things. And the person will be weighing around, let's say, 10 kg. And so if the child's weight, it's not what is expected of his age, then that should tell you that is abuse. And so inadequate weight gain, poor hygiene, we have consistent hunger, inconsistent school attendance, and then constant fatigue, report of lack of social supervision, delinquencies are all part of neglect. And so if you have your question, and then your question is around these things in terms of assessment, you should understand that it is neglect related to child abuse. Then the physical assessment that also tells you that the child is being abused. In fact, this one, if you have come across a question on child abuse, you might have seen it, that they will bring like unexplained bruises, bends, and fractures. And so that is why I was saying that at least if the child comes, let's say you have a 5-year-old child comes, and then there are bruises, fractures, and then the family is not able to actually tell you how come the fractures came by or how come the child sustained the fractures, that should tell you that it is an abuse. Or at 5 years, if it's not maybe some form of RT or something like that, it will be very difficult for a 5-year-old child to get what we call a fracture, if not maybe the person is playing football. You know that at 5 years of age, what kind of football that a person will, let's say, go and play for the child to get what we call injury. Or let's say they come and they tell you that the child went and then climbed a tree and then fell down. You look at the age, at 5 years of age, why would you leave a 5-year-old child to go and be climbing trees? And so that forms part of what we call neglect, leading to what we call the child sustaining those physical injuries. So unexplained bruises, bends, and fractures. There are bad spots on the scalp. So you look at the person, the head, and you realize there are some bad spots on the scalp. Will all tell you that the person has had some form of physical abuse. Then apprehensive child, they are extremely aggressive or withdrawal. So mostly with child abuse or physically abused children, the moment you go near them, you realize that the person will be withdrawing back from you. And so you realize the healthcare provider or the nurse wants to say that the male nurse is going to assess the child and the child is withdrawing back. When you realize that, it should tell you that that is an abusive person you are reading. Fear of parents, lack of crying. And so older infant, toddlers, young preschool child, when approached by a stranger, they tend to have fractures. So the fractures are mostly spiral fractures with a history of trauma from a sports injury. It's like I've seen. Poor school performance also forms part of what we call the abuse in terms of physical abuse. Emotionally, they will have speech disorders. So emotional abuse will have speech disorders. They will tend to have habits disorders such as sucking, biting, and then rocking are also part of what we call the emotional abuse assessment findings you can find with a child who is being abused. They tend to have psychoneurotic reactions, learning disabilities, and then suicidal attempts could also be common in these children. Sexually, if a child is sexually abused or raped, what are some of the things that you get to understand you need to assess for? They tend to have difficulty walking or sitting. Of course, if you have been raped before, a child has sexually been abused, they will definitely find it difficult to walk. They tend to have torn, stained, bloody clothing, pain, swelling, itching around the genitals is also common with these people. Deformities, they tend to have bruises and laceration around the genital area and the anal area. They are unwilling to change their clothing, so unwillingness to participate in gym activities so that people will spot them in terms of maybe they have some marks and all those things. Poor peer relations are also part of it. The poor school attendance. I've talked about baby shaking syndrome, where I said that there's some form of traumatic brain injury where there is no physical cause of the injury. So there's external signs of trauma are mostly absent in baby shaking syndrome. When you do your eye assessment, you're going to review retinal hemorrhage. They tend to develop bulging frontanels and then increased head circumference. Why? Because we said these people tend to have increased intracranial pressure as a result of cerebral edema. And so because of the cerebral edema, bulging frontanels and then increased head circumference are also much more common with these people. Lack of crying doesn't mean that if they need to cry, they don't cry. Yes, instance of where they will need to cry for you to know that they are crying, they will not cry. They will try to hide their pain. So these people tend to hide their pain. Okay. Interventions for child abuse. You need to make sure that you support the child during your assessment and let the child understand that you are required to report all your assessments. Okay. Let the child understand that as part of your duties as a nurse, you are required to report all neglect or all abuse, and then you also ensure safety. When you are doing your assessment, make sure the abuser is not there. Just like we said, you assess for injuries. Then baby shaking syndrome, if it is suspected, you might need to monitor what we call you might need to monitor the issues of intracranial pressure, head circumference, level of consciousness. You might need to monitor that. You need to report a case of suspected abuse. Nurses are legally required to report all cases of suspected child abuse to the appropriate legal or safety agency, so state agency. To place the child in an environment that is safe, preventing further injury. So this is why I was saying I need to show the child that you are there for her or him, and then you will ensure safety at all times. You document your information related to your suspected abuse in an objective manner. Okay. Then you need to assess the parental strengths, and then their weaknesses, their coping mechanism. Is it that when they are stressed out, that is when they go and then start abusing the child? You need to assess for the coping mechanisms of what we call the parents. You need to assess, or you need to presence or absence of support systems need to be assessed. Assist the family in identifying stresses, support system, and resources you can easily make use of. You need to refer the family to what we call appropriate support groups where they can get needs whenever they are stressed out. Nurses are legally required, I've said this, that they need to report all suspected child abuse or elder abuse to the appropriate local or state agencies. The state laws and procedures may vary from one state to the other. That is on child abuse and what's at least we need to know with regards to child abuse. If you have any inputs, any question you want to ask, you can bring it up before we do adult abuse. Yes, let me see. Mr. Yusuf, let me unmute you. Yeah, Mr. Yusuf, yes.
Oh, please, I just want to just ask something small about the characteristics of the wounds of this and the child abuse. I saw something like that where they said the like the edges of the wound is usually smooth. Yeah, and like uniform.
Okay, it's mostly uniform.
Yeah, mostly uniform, to suggest that maybe the hand or the leg is deep intentionally. It's intentionally deep inside what there's an fluid or any substance or chemical.
Okay. Okay, so if it happens on the right side, it will make like the left side will also be kind of affected. Is that what you're trying to say?
Yes, yes. And that also, I saw something also that toddlers are like the height of toddlers. I get the same like the height of listen, tables. So usually they run into tables, and then those bruises usually don't suggest that they are abused.
Can you take that point again? You said toddlers.
That I'm saying that there's the height of toddlers is usually the height of tables.
Yeah.
So when you have bruises around the forehead, usually that doesn't suggest it is an abuse, or that may not actually suggest that they have been abused, because the height of toddlers are almost the same as the height of office tables.
Okay, so it means that could be that they use their head to hit on the table and they develop those kind of marks.
Yeah.
All right, thank you. Let me hear from Madam Adepa.
Yeah, hello.
Yeah, Madam Adepa.
Again, across a question that the child.
Madam Adepa, can you raise up your voice more?
Hello, can you hear me, please?
Yes, I can hear you.
Okay, so I said I came across a question that said the child had a spiral fracture. So if you see, like, a spiral fracture is like it's round. So if the child fell down, they wouldn't have such a fracture. So if you see something like that, then you should know that it's an abuse.
Yes.
Then also I came across another question that they said when the nurse entered the room, the child was crying and wanted to go to the nurse, which normally, like, children will try to shy away from strangers to their parents rather. But this time the child wants to go to the stranger who is the nurse. So then you have to get a cue that there's a form of abuse going on. Thank you.
Okay. Thank you. So Mr. Izzy and Madam Adepa has added up. I think for the first one, the injury aspect, I did talk about it in terms of the fracture. Where is it? It's here. Spiral fracture right here. Okay. It is so uncommon. I mean, it's something like sports injury that can lead to spiral fracture. So if you have spiral fracture in a child, I mean, it should click in your mind that the child is being abused, and that is why. And they tend to also run away from what we call fear parents. So the second point she was making, it also here, fear of parents. So under normal circumstance, I mean, the child's supposed to run to the parents when in the midst of maybe a stranger. Let's say you, the nurse, the child doesn't know you. So under another circumstance, you expect the child to go to the parent, but the child is rather running away from the parent or fears the parents, then it should tell you that probably the child is being abused, and that is why you tend to have that situation. Any further input here, any further addition, so that we do have abuse of the older adults? And so let's quickly run through. It's also similar to what was said in child abuse, just that adult abuse is also, especially older people. And so abuse of an older adult involves physical, emotional, same thing, sexual abuse. Neglect is also the economic exploitation is also part of what you call older adult. Let's say the person, it's old enough who to take care of the person's yes. So caregiver issues. Yes. So I'll talk about it. So I mean the person in terms of economic intake financially could be a problem. So economic exploitation. Then older adults at most risk, those who are most at risk are those who are dependent. So in the comment section, someone has kept dementia clients there. And so dementia clients or Alzheimer's disease clients, we all know that when we learned about them, they depend on others for almost everything. And so such people mostly get neglected and get abused by their caregivers because of caregiver stress. So it's not just because the caregiver just wants to run away or just want to leave the older adult, but because of the stress in taking care of the person also get exhausted and ends up leaving the person. Immobility, that's people who are more, immobile, and then altered mental status people. These are the individuals who are mostly at risk of older adult abuse. Factors that could contribute to abuse and neglect could also include long-standing family violence, caregiver stress. So that is where I was talking about the issues of dementia or dementiated clients, and then the older adult increasing dependency on others. So let's say you are a nurse, you have your older, maybe you stay with your grandmother, the grandmother always needs your help. Charlie, it's not easy. Look at how you have to combine your work with taking care of the person. Sometimes it's not just like you want to neglect the person, but as part of the stress and then the demands, you might end up probably in a way, leaving certain needs of the person. So these are some of the things that could contribute to abuse. Victims may attempt to dismiss the injuries as accidental, and then the abusers may also prevent victims from receiving proper medical care to avoid discovery. These are some of the characteristics of abusers and then the victims. Victims are mostly isolated sexually by what we call the abusers. So the abuser will always want to isolate what we call the abuser. Similarly, we talked about the assessment findings. If the older adult is being abused physically, some of the things you want to see or you see is that there are going to be some form of fractures are also common with these people. And so you have fractures, dislocation, and then sprains can all happen, abrasions, and then bruising, lacerations, all could indicate that the older adult is being neglected. Pressure sores, especially if the person is not being taken care of and maintained in a certain position for a very long time, the person could develop what we call pressure ulcers or pressure sores. Wound or punctured wounds are also indications of what we call abuse in older adult. Burns and skin tears. These are some of the physical assessments that you can relate to what we call older adult abuse. The sexual aspect, just like we talk about in kids, they tend to, or children, these people they have torn or stained underclothing in terms of their underwears. They are mostly torn. They tend to have discomforts, bleeding in what we call the genital areas, could also indicate that they have been abused sexually, difficulty in walking and sitting, and then unexplained genital infections or diseases. It's very hardly for an older adult to develop genital infections or let's say STI. It's very uncommon. So if you have the older adults having unexplained genital infections or diseases, then it should probably tell you that maybe someone might have abused the person sexually. That is why. Emotionally, they could tend to have confusion. They tend to have fearfulness and agitations, and then changes in appetite and weight. In fact, the weight one is very common in your questions. They will tell you that, you have an older adult who has lost a certain amount of weight over a certain period of time. And then that could tell you that the person has been abused or neglected. That is why the older adults is losing such weight. They tend to also withdraw, lose interest in what we call social activities. When they are neglected, you see them appearance in terms of dressing, how they are kept, they are unkept. So that is this heaved appearance, inadequate or inappropriate dress. They tend to have issues of nutrition, issues of hydration. So dehydration, malnutrition, very common with them. That is why they tend to lose weight. They have lack of physical needs such as their glasses. So that is also another important point. When you are reading your question and you come across a question where it says that the older adults, comes and then tells you that like you have gone to visit the person or on your assessment, you realize that the person has lost their eyeglasses has broken, their hearing aids have gone missing or has spots, and then their dentures have all removed. If you find this in terms of your assessment or part of your question for older adults, it should tell you that it is a neglected question you are reading, or it forms part of what we call neglect. Signs of medication overdose. I mean, the person doesn't know how to take their medication, or the one who is responsible to make sure they are serving the medication is not there. And so they tend to overdose the medication, or sometimes not to even take the medication at all. But most of the times it's overdose because they might not be able to know what amount they are supposed to actually take. Then in terms of the economic exploitation, inability to pay their bills, and fearful when we discuss something about finances. They are mostly confused about their finances, and then inaccuracy, no knowledge of finance. So that talks about the economic exploitation. Interventions for adult abuse. Here, you need to also assess for your injuries. And then you need to treat the physical injuries as well. Assess for the wounds, and then you treat any form of wound. The person may be having pressure ulcers. You might need to also dress them. You need to make sure that the older adult is removed from that threatening environment. And then you need to adhere to that mandatory reporting. So this also forms part of instances where you need to report. And so as a nurse, you need to report all forms of abuse. So you need to also notify the case worker of the situation. So other words, they use social worker. Okay, in other books, they use social worker. So the case worker or the social worker are those who are responsible for issues of abuse in terms of adult abuse and all forms of abuse. So you need to report or notify the case worker of the abuse. And then you need to document the occurrences, your findings, your actions you've taken, and then the victim's responses. You need to ask if any injury is as a result of someone harming them. You need to report cases of suspected abuse to appropriate authorities. And then you need to separate the older adult from the abusive environment. So at this time around, you don't say that the older abuse should decide as and when they want to leave the caregiver. This time around, you are required to remove the older adult who is being abused from that abusive environment. And if possible, you need to contact the adult protective services for assistance and then in placement whilst the abuse is being investigated. You need to explore alternate living arrangements that are less restrictive and then disruptive to the victim. The older adult who also has been abused may need assistance for financial or legal matters. So that is when the legal issues comes in. Referral for emergency community resources are also very important. And then you need to assess the caregiver. Like I said, when working with a caregiver, assess the need for, respite care or, counseling to deal with what we call the caregiver stress. So where I was saying that nobody would want to abuse their grandmother, let's say they are staying with their grandmother, but because of stress that comes out, sometimes it's very difficult. So you need to assess the person, support the person, ask about their stress that they are going through in caring for the older adults. And then we might need to also offer what we call support in terms of asking if they will need to let the person go in for respite care or go in for what we call long-term care facility where they take care of the older adults for the person. The last thing we do on this is rape, and I think that is this. We are left with these two slides, and I'm done with mental health. So let me your time small so that we finish this so we can start a new thing going in tomorrow. Last thing I'm talking about is rape. When it comes to rape, what we need to know is how to do your assessment, how to take care of the person. Are you going to allow a rape person to bath? What are some of the things you are going to do for a rape person? Someone who is suspected of rape, who is supposed to come and assess the person. We need to know all these things. And so we all know rape. It's not now coming to learn about rape, but we all know that engaging another one in sexual acts or sexual intercourse through the use of force, coercion, and then without the consent of the individual. We all know this. So the victim is not allowed by it's not required by law to report the rape or the assets. I mean, it's the person's will the person wants to report the report. Some people may want to keep it for whatever reason it takes. So often the victim is mostly blamed by others and receive no support from significant others. We have different forms of rape. So acquaintances rape, we have statutory rape where you need to legally report, especially if the person is in terms of age, less than what we call the required legal, age to consent for sex. And then if the minor consents, that is acquaintances rape involves someone known to the victim. Now, my interest is on assessments, interventions for someone who is being raped. So when it comes to rape, our assessment is very important. We need to perform assessments in a quiet and a private area. You need to report to the appropriate domestic violence department. You need to stay with your client. Safety is very important for people who have been raped. You need to assess for physical injuries and then you treat the injuries for appropriate. You need to assess the victim's stress level by performing treatment and then procedures. When it comes to this point, explain to the victim why showering, bathing, douching, or changing clothes cannot be done until an examination has been performed. That point is very important as to whether you will let the person bath, do anything that can alter the evidence. And so because of evidence, when someone is rushed in and you have to do your assessment, just do your assessment. Report what you've seen. Don't allow the person to bath. Don't allow the person to put anything around her genital area that can alter what we call the evidence. Yeah, clothing, everything. Let it be on the client until the client has been examined by the appropriate authority or the person who is required to do the assessment. And so you need to make sure that that has been done. You need to make sure that you obtain consent from the victim for examination, photographs, laboratory tests, and the release of information and laboratory samples. Before you do any of these things, you might need to take the person's consent. You need to assist with what you call pelvic and other examination and obtain specimen to detect body fluid of another person. We offer shower and fresh clothing to the victim after the examination. And so this is where I was saying that the victim can only be allowed to change their clothing and shower or take bath or douche only after the victim has been examined or examination has been completed by the most appropriate person responsible to do the examination. You need to preserve any form of evidence that you have to treat physical injuries and then provide clients with safety. Medications are necessary. The reason why medications are necessary, the medications, most of them are prophylactics. It could be, let's say, ART medications, because you might not know the status of the victim. And so some of them might be giving antiviral medication, some of them may be giving medication to help maybe prevent what we call STIs. And then some of them are even put on what we call contraceptives, because you might not know whether the person probably to just help prevent what we call pregnancy. And so those are some of the medications that can be given in instances of rape. Document all your events in terms of the care you offer to the client. Reinforce the victim that, so this is more of like support, and that surviving the assault is most important. So if the victim survived the rape, the victim did exactly what was very necessary to stay alive. So this is more of a motivational thing. You need to refer them to the crisis intervention and then support group. Then I think that brings us to an end on rape and then what we need to understand with regards to rape. And like I was saying, always make sure before the client showers, bath, and all that, the client has been assessed and the examination has been done by the healthcare provider, and they have special nurses or people who are well trained to examine the client in instances of rape. But as for you, the nurse, what you need to do is just to do your normal assessment, look out for any form of injuries and all that, and report any of such thing if you see. But the nurse or the person will need to come in and thoroughly assess the client, especially the genital areas and all those things, the clothing, so that they could pick any form of evidence that could indicate that the person has been abused. And that brings us to an end to what I wanted to do with you guys today. I don't know if we can do questions, or if you guys are tired, then that means I will leave it here for today. But yeah, I'll prefer if we go through some few questions and then we drop it then as well. If you have any inputs. If the victim refused to consent to examination, photographs, what do you do? It means that if the person refused to consent, you cannot go ahead to do your examination, to take photographs. That is why you need a person's consent. So it's consent. It's just like the person was going in for surgery. The person needs consent. The person says, I won't consent. Can you force the person? You cannot force the person. So you leave the person. Okay. But I'm sure the person will definitely allow you to. That is why you need to provide privacy. You need to ensure safety and all that. Sometimes it's, let's say you are to do those things openly, especially in our setting in Ghana here. We get a rape case and it's like everybody's rushing in there to come and see the person. Over there, the systems are well placed. The systems are well in order. So you need to ensure that the person is protected. Safety, privacy, definitely the person will allow you to do your examination and any form of photographs that need to be taken. Oh yes, you go ahead to report. Of course, if the person says you won't allow me to report, you need to report that to the appropriate authority that the person says you won't allow me to report. This rape victim can go through, yes, PTSD. We talk about it, so it's form part of those instances where someone can go into PTSD. Who is supposed to do the examination? Like I said, the examination, it's not basically done by the healthcare provider. Okay. Sorry, it's not done by the nurse. Let me put it that way. So you need, forgotten that, what's the name? That's I want to, they are called forensic. I think they are forensic nurses here. They are forensic nurses. So those people are well trained to do such assessments. And so they will assess the client to find out any evidence of any form of rape. Okay. Any further question, inputs here before we move on? Sexual assault nurse examiner. All right, thank you, Madam Mavis. So Madam Mavis has kept the one who is responsible to do the assessment. Sexual assault nurse examiner. All right. Malnutrition and safety. Which one is a priority? Child abuse. NCLEX is always safety first. Ensure safety before you attend to. Definitely when it comes to malnutrition, you not use one day to rectify that. It will take a lot of time before you correct a situation of malnutrition. Okay. All right. So I have a question here. Which of the following individual is at highest risk for committing suicide? A is 71-year-old male who is alcohol user, independent-minded. B is 16-year-old female, diabetic, with 2 best friends. C, 47-year-old male, schizophrenic, unemployed. D, what's 57-year-old male, female, depression, active in church. Who is ready to answer for us? Want someone to tell us why we're opting for C? Anyone to come in?
Can you hear me?
Yeah, I can hear you, Madam Eni.
Okay. I was actually going for C, being that one, it's a male, and number two, no protective factor, in terms of him being unemployed. I think, yeah.
Mhm.
Over
Alright, so
A, I think A has A is quite independent. B, she's got two best friends, and then D, quite active in church. Again, a supportive network. I think.
all right. Anyone with a varied view here? So when I saw this question, I saw the answer, I was very amazed. Okay. The answer is A. Now let's look at the what is it? The risk factors here. You realize that we said that the risk factors, one of them is, we said it's more common in older adults and adolescents. So when you take, so now the answers are now on the option C and then A. That is where you might come in. When you take the age, if you remember the risk factors, we said adolescents and then older adults. So in that instant, when you take the A, if you have to do your subtractions and addition, you realize that the A will take over because of the age here. So we can now count the number of risk factors. Now, male, when it comes to risk factors, male and female, the statistics are that males are, like, in terms of attempts, okay, the females attempt more, but the males complete what we call the suicide faster than what we call the females. So the females try to, like, in terms of the frequency of attempting to commit suicide, females does it like more frequently, but to complete it, males complete suicide attempts more than females. So yes, they are all males, so that will cancel each other. Drug abuser, this person uses alcohol. So we can say that, so now they are all males. So this one is now having two risk factors. We've counted two risk factors here. This person is schizophrenic, so another risk factor here. So this person has now gotten only one risk factor, if you want to. Only one risk factor, because they are all males, so that will cancel each other. The age, this one is older. We said that older people are more at risk to commit suicide. This one is more younger person, younger adults. So that is not a concern here. Now, unemployed, yes, is a part of it. This person is independent-minded. This independent-minded means that this person wants to be alone without other people. Like they don't want to get involved in anyone. So these people are like more reserved kind of people, which is also, they are not social. Okay, so let me put it this way. They are not sociable. So this person is not sociable, independent-minded and all that. And you know, if the person is not sociable, the probability of committing suicide is high. So at the end of the day, this person has age on his side, which is a risk factor. He's a male, which is a risk factor, uses alcohol, much more reserved, independent-minded. So has all risk factors, or 1, 2, 3, 4 risk factors. This person has only 3 risk factors. 1, 2, 3. The age here is not a risk factor. That is why the A is the answer. All right. So next time when you get such question, try to let's open our eyes. Unless someone has a contra information or want to debate it with his rationale. All right. Let's do another one, okay? I know I've taken your time, but let's do some questions, okay? I personally need to close, but I just want to do questions, so tomorrow I won't go back to this. A patient has a history of suicidal ideation. The nurse understands that the patient is at highest risk of self-harm at which of the following times? Immediately after a family visit, B, on the anniversary of significant life events in the patient's life. C, during the first few days after admission. D, approximately 2 weeks after starting antidepressant medications. Hello. Oh, are we tired? So that I was so close. So if we are tired, we close. Who is answering for us? Ooh, so I'm getting B, I'm getting D. This is what I like. Okay. So the B should open up and tell us why B. The D should tell us why D. No. The B should tell us why B. The D should tell us why D. No one can defend the answer. Let's go on the end. So the answer is D. Approximately 2 weeks of starting antidepressants. Remember, I said that antidepressants typically start working within 4 weeks, or let's say, yes, from 2 weeks going. The reason why we're saying that approximately 2 weeks of starting antidepressants, I have said it. People who are put on antidepressants are at more risk of, like, they are at high risk of suicide because their energy will increase all of a sudden and their attempt to commit suicide will be there. Now, I was wondering why this is not the first time people are going for the B. Last time, some people were also going for the B. Now, on the anniversary of the significant life event in the person's life, why would someone try to commit suicide at the point when the person is celebrating a certain life event in his or her life? Let's say the time that you got married, and the next like 2 years time you are celebrating your 2 years anniversary or 1 year anniversary. And do you think that is when the person will commit suicide? Those who were going for the B, that's why I wanted you to come up why you were going for the B. Because you are celebrating a certain probably achievement or an anniversary, let's say the time you graduated and it's 2 years, and now that you want to celebrate that kind of moment in your life. So why would you think that the person will want to commit suicide then? That's why I wanted you guys to tell me why you were going for that. So I now have the answers up. So Madam Sarah, your hand is up.
Yes, so I was actually thinking on picking the D. But I remember the medications, you said when they are the antidepressant, it takes 2 to 4 weeks.
Yeah.
So does it mean from the 2 weeks you have the effects of the...
Oh, yes, you start seeing the effects of the medication, but just they're not full effect of the medication.
So that is why I didn't choose.
Oh, yes. So you start seeing the effects. So if you are seeing the effects, yes. Yes.
But
So you
the
say you went for
the B. So the B, I was actually also thinking about it. It's like a practical thing. It do happen. Sometimes people who want to commit suicide, they surprise you and they pick days that you least expect.
Okay.
So
So
I'm sure that's why they chose
people were
those.
going for that. Okay.
Yeah.
All right. Let me hear from Madam Asian. I think she went for B. Madam Asian, you went for B. If you drop your hand, I wanted to hear from you. Yes, Madam. You can go ahead, Madam Rahman. Oh, I've muted it again.
Hello,
Yeah.
Bosamingo.
Yeah.
I always went for B, and because the G, I wasn't convinced because antidepressants, they start working from 2 to 4 weeks.
Yes.
So taking that one, that one got me more confused. So I didn't have
Okay.
any option than to go for the
To
B.
go for the B,
So
okay.
please explain the D well for us. That I'm still not convinced.
I'm saying that, yes, 2 weeks, approximately 2 weeks of starting antidepressants. We know that the antipsychotic, the antidepressant, takes about 2 to 4 weeks before they start to work. So the moment the medication starts to work, the person level of energy. That's why I was saying that the person will tell a few weeks after I started my medication. Some of them, they will even, in some question, they will even state the number of weeks. They will say that, oh, the moment, like some few weeks after I just started my medication, my antidepressant, I've realized that I have gained some form of energy, or my mood has like improved all of a sudden. That is the idea behind the option T. That is approximately 2 weeks after starting antidepressant. We know that by then, the effect of the medication has kicked in, has started. And so tendency of the person committing suicide at that end is very high. That is why the option D is correct. Because at 2 weeks, yes, the medication effect might have been seen, but not full effect. And it is at that time that their energy starts to increase. And so at the point where their energy starts to increase, suicide attempts also start to go up, or suicidal thoughts also increases. That's why the D is the best answer here. Madam Tina, I think I've unmuted you.
Please, so this explanation, I'm finding it difficult to understand. Does that mean when the person was depressed, the person was thinking about suicide?
No.
And then once the person had the energy to now commit the suicide, that's why he or she is committing it or what? Because if you
Yes,
are on
so
antidepressants,
yes,
it's
so
supposed to make you
yes,
feel better so that you
yes,
don't think about all these things. So why is it that
yes,
once the drugs start kicking in,
yes,
then you
yes.
want to go and kill
So
yourself? I don't understand.
during suicide, sorry, during depression, we learned that it is during depression that the suicidal thoughts are there.
Yes.
Their hopelessness. I mean, they feel that they are not even supposed to live at all during intense depression. But they don't have the energy to commit it during the time of suicide, during the time of depression, because during the time of depression, the person is more reserved, no energy to commit the suicide. Even though they have the suicidal intent that they want to end their life, but they cannot move to go and do it because they don't have that energy. They are always timid and all that. So committing the suicide becomes very difficult at that point, even though they have the intent. The only thing they need to commit the suicide is energy. What will ginger them to go and commit the suicide? Because the thoughts are still there. So the moment they start the medication, then their mood will start changing. The energy will still come. Still, the medication has now started working. So they start get some form of energy. The moment the energy kick in or their energy rise up, then they now want to go and then commit the suicide. So that is why the moment you start your antidepressant, you need to monitor the person for the actual suicidal thing the person is thinking of during the suicide.
Okay, thank you.
There was another hand. Is it a bit? Oh, the name. If we could raise your I saw the name, but that was Madam Sarah. Your hand is up again.
Yeah, so I wanted to ask about the same suicidal. So does it mean that those people, we have to find out from them before they start the antidepressants, like
Oh,
if they have any ideas of the suicide?
Oh yes, you need to ask them. You need to ask about suicidal thoughts. You need to ask about But
Okay, so when
you
they
as a
start
nurse,
the
you need to understand that as part of assessment
okay,
for people who are depressed, suicide is key. Suicide is part of them. So always be watchful for suicide with depressed clients, even before you go ask the clients whether they have intent of harming themselves or ending their life. Some of them will even open up to you that if I die, grandpa, it's even better than me living. The suicidal clients, they will be making those kind of statements.
Okay.
During a regular home, have we answered this? During a regular home visit to an elderly client, the nurse observed that the client has feeling of hopelessness and despair. The client says, I am old and my life has no purpose anymore, but promise me you won't tell anyone. How should the nurse respond? A, don't worry, I won't tell anyone else. B, I am sorry, but I can't keep that kind of secret. C, let's talk about something to cheer you up. D, what can we do to help you feel better? So this is another question. Another interesting question. All right. Is there anyone who wants to talk, who wants to tell us why he or she is going for that very answer? Obapa may want to talk. Let me unmute Obapa May. All right. Obapa May can go ahead.
So I'm going for the D because A, don't worry, I won't tell anyone else. It's not therapeutic. I'm sorry, but I can't keep that kind of secret. It's just like a statement. You are not doing anything to help the patient voice out what is actually causing her problems or what is making her make that statement. So she cannot come out with her worries.
All right.
For you to help out. And then the C, let's talk about something else, something to cheer you up. It's kind of diverting the actual problem of the patient. Like you are just swerving away from the main concerns. And then what can we do to help you feel better? It's kind of open-ended question that will let the patient to come out with what is actually causing
bothering them.
Yeah.
Okay. All right. Madam Essien. Now, Rebecca, you will come and tell us why you're going for B. So prepare. Now, Rebecca and then Nancy. I'm interested in you guys, your answers. So you guys should raise your hands so I will meet you. So Madam Essien, kindly go ahead.
Okay, so I went for D because I feel it's more therapeutic. We are giving the patient the opportunity to also express and talk about how she feels. Yeah, that's it.
Okay, thank you. Now, Rebecca and then Madam Nancy, you went for B. I'm interested in your answer. Oh, you are not ready to tell us why they are going for the B. So, in fact, the answer is the B. Sorry, I'm sorry, but I can't keep that kind of secret. Now, look at what the client is demanding. The client is asking you to keep a certain secret that you're not supposed to keep. That is what the client is asking you. But promise me, you won't tell anyone. Are you not supposed to tell your healthcare provider? Are you not supposed to report when you notice someone has a suicidal intent before you even ask the person to, voice it out their concerns? And so the best answer here is to tell the client, be open to the client. Don't let the client understand that, you are not going to tell anyone of their suicidal intent. No. Let the client understand that you are required to report when you need to report situations. And so these situations require you to report. And so you cannot keep the secret. That is the best answer. Before you even come back to ask the client to express themselves in terms of, ask more about their suicidal intent and all, what they will make them to speak more. So the best answer here is to go for the option B, because I am sorry, I cannot keep this kind of secrets. So Yusuf, your hand is up. I'm trying to unmute you.
Hello.
Yeah.
Please, looking at the question, what is really the client's problem? Because they said the nurse observed the client has feelings of hopelessness and despair. That's also a problem. So the client says, I'm old, and my life has no purpose anymore. I think this is describing the client's not having hope. And then I don't see why, like, we left everything about the client's hopelessness to concentrate on only this and keeping the secret.
So what do you think is the answer?
D,
and what's the reason? You say you are going
for D to say what can we do to help you?
What can we do? That's why I'm saying that, Mr. Yusuf, perfectly. What can we do to help you? Let the client speak more. That is fine. Open-ended question. But I'm telling you that the client is asking you, the nurse, to do something for her. In the question, when you read the stem of the question, it's not about, let me land. It's not about the assessment findings you have noticed where the client is saying that I am feeling hopeless and then my life is, the client is requesting something from you that you should do for her by keeping the secret, not telling anyone about what they are feeling. And everything in the question is pointing to that the client is tempting or is thinking of that these are suicidal thoughts. This is a depressed client who has suicidal thoughts. And the client is asking you, the nurse, that don't tell anyone. This is where the issue of being, you remember therapeutic communication, we said what? Don't promise the client what you cannot do. Okay, be open to the client. Let the client understand the situation. And so at this point, the client is telling you to keep a certain secret where you're not supposed to keep that secret. So letting the client know that you cannot keep that secret at this point is the most important thing you have to do, even before you ask the client to express themselves more. If you choose the option D, it means that you have left that part where the client is asking you to do something for her. And that is the main concern at this point. Yes.
But then, when you choose to say that I'm sorry, but I can't keep that kind of secret, like, wouldn't that end the conversation there? Instead of like going in like further, you understand? To know what is like to know what.
So you are reading more into the question. So you are now thinking. So you are now thinking that when the nurse makes that statement, it will end the conversation. You are now thinking through the question now.
That's what it says. I can't keep that kind of secret.
Yes. So you are now thinking through the question now. If you make that statement will cut every conversation off. And that is wrong. We are not supposed to think that way.
Because there is D. Okay, all right.
There was another hand up. Is there anyone with any other? That's what I'm saying. These are interesting questions. Okay, now Rebecca says she can't. I wanted you to raise up your hand, or I would have, unmuted you myself so you come in. So the perfect answer is the B. Okay, telling the client that you cannot keep the secrets. Is the perfect answer is the B. Before you even come to ask for the client to further, tell you their situations and their issues. Let me leave it here for today. We've done a lot, okay? I don't know if anyone has any further questions or input to make based on whatever has been said.